Statin therapy, mechanistic basis, clinical application, and management of cholesterol biosynthesis inhibition. Cardiovascular disease accounts for 31% of global deaths, and elevated low-density lipoprotein cholesterol, LDL C, is the single largest modifiable risk factor, contributing to an estimated 2.2 million premature deaths annually. Statins inhibit 3-hydroxy-3-methylglutaryl coenzyme A reductase, HMG CoA R, the rate-limiting enzyme of hepatic cholesterol biosynthesis, producing a dose-dependent upregulation of LDL receptors and a 3055% reduction in LDL C per 10 mg increase in atorvastatin equivalent dose. Diagnosis relies on fasting lipid panels with LDL C thresholds defined by the 2019 ACC/AHA guideline, greater than or equal to 190 mg per deciliter for primary hypercholesterolemia, 70100 mg/dl for secondary prevention, and ASCVD risk calculators that stratify patients into less than or equal to 5%, low, to greater than or equal to 20%, high, 10-year risk. First-line therapy consists of high-intensity statins, e.g., atorvastatin 4080 mg daily, combined with lifestyle modification targeting less than or equal to 5% body weight reduction, less than 150 minutes per week of moderate-intensity aerobic activity, and saturated fat intake less than 7% of total calories. Key points. Note: high-intensity statin therapy, atorvastatin 4080 mg daily or rosuvastatin 2040 mg daily, lowers LDL C by an average of 50%, range 4.5–5%, within 4 weeks. Primary hypercholesterolemia is defined by LDL C greater than or equal to 190 mg per deciliter, greater than or equal to 4.9 millimoles per liter, or by a 10-year ASCVD risk greater than or equal to 20% per ACC/AHA 2019 guideline. Statin-associated muscle symptoms, SAMS, occur in 5–10% of patients. Clinically overt rhabdomyolysis, CK greater than 10 times ULN, occurs in almost equals 0.1% of treated individuals. The number needed to treat, NNT, to prevent one major cardiovascular event over 5 years is 27, 95% CI 2431, for patients with prior ASCVD receiving high-intensity statins, Jupiter, 2008. Co-administration of strong CYP3A4 inhibitors, e.g., clarithromycin, increases atorvastatin AUC by 2.5-fold. Dose reduction to less than or equal to 20 mg daily is recommended, FDA label. In patients greater than or equal to 75 years, a moderate-intensity statin, e.g., rosuvastatin 510 mg daily, reduces all-cause mortality by 14%, HR 0.86. 95% CI 0.78–0.95, HOPE3, 2016. For chronic kidney disease, CKD, stage 3, eGFR 3059 ml/min/1.73 square meter, rosuvastatin 510 mg daily maintains efficacy with no dose adjustment. Atorvastatin requires no adjustment but monitor hepatic enzymes. In pregnancy, statins are category X. Pravastatin 1020 mg daily is the only agent with limited data suggesting no teratogenicity, but guidelines, AHA/ACC 2022 advise discontinuation. Non-statin LDL C lowering agents, e.g., evolocumab 140 mg subcutaneously q2 weeks, achieve additional 1520% LDL C reduction when added to maximally tolerated statins. Lifestyle modification targeting a 5% weight loss, less than or equal to 7% saturated fat intake, and greater than or equal to 150 minutes per week of moderate intensity exercise reduces LDL C by almost equals 10% independent of pharmacotherapy. Overview and epidemiology. Hypercholesterolemia, coded as E78.0, pure hypercholesterolemia, in ICD-10, affects an estimated 108 million adults worldwide, representing 13% of the global adult population. World Health Organization, 2021. In the United States, 34.5% of adults greater than or equal to 20 years have elevated LDL C, greater than or equal to 130 mg per deciliter, based on NANS 20172020 data, with prevalence rising to 48% in men aged 4564 and 55% in women aged 6574. Regional variations are pronounced. The highest prevalence is almost equal to 58%, is observed in the Middle East, while the lowest is almost equal to 9%, occurs in sub-Saharan Africa. Global burden of disease, 2022. Age is the strongest non-modifiable risk factor. Each decade after 30 years adds a relative risk, RR, of 1.3 for ASCVD events. Male sex confers a RR of 1.5 compared with females, and African American ethnicity is associated with a 1.2-fold higher prevalence of familial hypercholesterolemia, FH, versus Caucasians. Economically, dyslipidemia accounts for US $110 billion in direct medical costs annually, with statin therapy alone contributing US $5 billion in drug expenditures but offsetting US $20 billion in avoided cardiovascular hospitalizations. American Heart Association, 2020. Modifiable risk factors include dietary saturated fat. Greater than 10% of total calories increases LDL C by 0.5 millimoles per liter per 1% increase. Physical inactivity. Less than 150 minutes per week of moderate activity raises LDL C by is almost equal to 8 milligrams per deciliter. Smoking. Current smokers have a 1.4-fold higher LDL C, and obesity. BMI greater than or equal to 30 kilograms per square meter raises LDL C by 12%. Non-modifiable contributors comprise genetic FH. Heterozygous prevalence is almost equal to 1/250th. Homozygous is almost equal to 1/300,000, and polymorphisms in SLCO1b1, C.521T greater than C, that increase statin AUC by twofold, predisposing to SAMs. Pathophysiology. Cholesterol biosynthesis proceeds via the mevalonate pathway, wherein HMG CoA reductase catalyzes the conversion of HMG CoA to mevalonate, a rate-limiting step consuming 2 NADPH molecules per cycle. Statins, structurally analogous to HMG CoA, competitively inhibit this enzyme with key values ranging from 0.1 nanomolars, rosuvastatin, to 5 nanomolars, levastatin. Inhibition reduces intracellular cholesterol synthesis, prompting upregulation of sterol regulatory element binding protein 2, SREB2, and consequent transcriptional activation of LDL receptor, LDLR, genes. Hepatic LDLR density increases by 2-3-fold, enhancing clearance of circulating LDL particles via clathrin-mediated endocytosis. Genetic variants in LDLR, e.g., LDLR C.1060 plus 5G greater than A, diminish receptor expression, accounting for 85% of FH phenotypes. In addition to LDL-C reduction, statins attenuate isoprenoid intermediates, farnesylpyrophosphate, geranylgeranil pyrophosphate, thereby modulating Rho kinase activity and exerting pleiotropic anti-inflammatory effects, evidenced by a 15% reduction in high-sensitivity C-reactive protein, HSCRP, in the Jupiter trial. Median baseline HSCRP equals 2.5 mg per liter. Clinical presentation. Hypercholesterolemia is largely asymptomatic. Greater than 95% of individuals are identified through routine lipid screening. When symptoms manifest, they are typically indirect, such as exertional angina, present in 28% of patients with LDL-C greater than or equal to 190 mg per deciliter and established ASCVD, or peripheral claudication, 12%. In elderly patients, greater than 75 years, atypical presentations include dyspnea on exertion, 22%, and cognitive decline, 8%, that may be misattributed to age rather than underlying atherosclerosis. Diabetic patients often present with silent myocardial infarction. In the ACCORD trial, 18% of diabetics with LDL-C greater than 130 mg per deciliter had unrecognized MI on cardiac MRI. Physical examination yields limited diagnostic specificity. tendon xanthomas are present in 1 to 15% of heterozygous FH patients and have a specificity of 98% for FH. Corneal arcus appears in 6% of individuals greater than 50 years with LDL C greater than 160 mg per deciliter. Specificity is almost equal to 85%. Red flag findings necessitating urgent evaluation include acute chest pain with ST segment elevation, new-onset neurological deficits, and rapidly progressive peripheral ischemia. Diagnosis. The diagnostic algorithm begins with a fasting lipid panel, greater than or equal to 8H fast. Reference ranges, NIH, 2022, are total cholesterol less than 200 mg per deciliter, LDL C less than 100 mg per deciliter, HDL C greater than or equal to 40 mg per deciliter, men, or greater than or equal to 50 mg per deciliter, women, triglycerides less than 150 mg per deciliter. LDL C is calculated via the Friede-Wald equation when triglycerides less than 400 mg per deciliter. Direct LDL measurement is recommended when triglycerides exceed this threshold, with a sensitivity of 92% and specificity of 94% for detecting LDL C greater than or equal to 130 mg per deciliter. Secondary causes, e.g., hypothyroidism, nephrotic syndrome, obstructive liver disease, must be excluded by measuring TSH, reference 0.44.0 μ/L, serum creatinine, and liver function tests, ALT, AST less than 40 U/L. The presence of FH is confirmed by the Dutch Lipid Clinic Network, DLCN, criteria, where a score greater than or equal to 8 indicates definite FH. Probability is almost equal to 95%. Management and treatment. Statin therapy is not an acute emergency. However, patients presenting with acute coronary syndrome, ACS, should receive high-intensity statin loading within 24H, atorvastatin 80 mg PO once, or rosuvastatin 40 mg PO once, per ACC/AHA 2019 guideline. Continuous cardiac monitoring, serial troponins, and initiation of antiplatelet agents, aspirin 162325 mg loading, then 81 mg daily, are mandatory. High-intensity statins are defined as agents that achieve greater than or equal to 50% LDL C reduction. Key points: atorvastatin 4080 mg PO daily, tablet, average LDL C reduction 4555% within 2-4 weeks. Monitor ALT/AST at baseline, 6 weeks, then annually. Rosuvastatin 2040 mg PO daily, LDL C reduction 5055%, requires baseline CK measurement in patients with prior SAMs. Simvastatin 80 mg PO daily, not recommended in patients greater than 75 years due to increased myopathy risk, FDA boxed warning. Ezetimibe 10 mg PO daily, additional LDL C reduction is almost equal to 18%, Improve IT, 2015. References. 1. Saida Ng et al. The Multifaceted Biology of PCSK9. Endocrine Reviews. 2022, 43, 3558-582. PMID, 35552680. https://pubmed.ncbi.nlm.nih.gov/3555260. DOI 10.1210/NDREV/NAB035. 2. Rusicka M. et al. Bempedoic acid, for whom and when. Current atherosclerosis reports. 2022, 24, 10791-801. PMID 359000636. https://pubmed.ncbi.nlm.nih.gov/359000636. DOI 10.17007/S11883-022-01054-2. 3. Dingman R. et al. Evinacumab, Mechanism of Action, Clinical and Translational Science. Clinical and Translational Science. 2024, 17, 6E13836. PMID, 388453993, https://pubmed.ncbi.nlm.nih.gov/388453993. DOI, 10.1111/CTS13836. 4, Wang K. et al. Remnant cholesterol and atherosclerotic cardiovascular disease, metabolism, mechanism, evidence, and treatment. Frontiers in Cardiovascular Medicine. 2022, 9:913869. PMID, 363244753, https://pubmed.ncbi.nlm.nih.gov/363244753. DOI, 10.3389/FCVM.2022.913869. 5, Summers T. et al. Statins and cardiomyocyte metabolism, friend or foe? Journal of Cardiovascular Development and Disease. 2023, 10:10. PMID, 378878864, https://pubmed.ncbi.nlm.nih.gov/378878864. DOI, 10.3390/JCDD10100417. 6, Tajbakhsh et al. Statin-regulated phagocytosis and efferocytosis in physiological and pathological conditions. Pharmacology and Therapeutics. 2022, 238:108282. PMID, 3613064, https://pubmed.ncbi.nlm.nih.gov/3613064. DOI, 10.1016/J.Farmthera.2022.108282. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.